Unni. I'd like to see a show of hands of how many people don't know who he is. Good. Dr. Unni doesn't need an introduction. We are very, very privileged to have Dr. Unni become a member of our faculty in our department. He decided to come out of retirement to save us and to help us out. And it's a pleasure and a privilege, not only because of him being one of the most prominent and recognized pathologists in the world, but also because it's such a pleasure and a joy to work with him. He is truly a role model for not only our residents, but for all of us. So it's my pleasure to have Dr. Unni here.
Thank you, sir. Can you all hear me? How can you answer questions? People who can't hear me are not going to hear the question, right? So how are they going to answer? I was going to talk a little bit about some of the lessons I have learned. You know, when people, chairman of the department, ask you to talk about philosophy, that usually means that the chairman thinks that you are not good enough to talk about any specific subject anymore. But you may be able to talk a little bit about your experience. By the way, I saw Dr. Cooper come back in. Is that right, Tom? That was an amazing talk that Tom gave. Different subjects, oropharyngeal carcinoma, with all kinds of special studies, which I don't understand anything of. And then talk about fibroblastic tumors. Which reminds me of a story. In the old days, there was a famous pathologist at the University of Minnesota called Bell. And there is a symposium named after him. The Minnesota Society of Clinical Pathologists has a slide seminar every fall. I think it's in November this year. And it's a great seminar, usually. And it is named after him. And one of the pathologists at the Mayo Clinic, which is a long, long time ago, before my time, went up to spend a day with Dr. Bell to learn neuropathology. And when he came back, Dr. Doherty asked him, what did you learn about meningioma from Dr. Bell? And he said, well, Dr. Bell has about 6 meningiomas in his collection, but 10 different types. And that's what Dr. reminded me of. Myofibroblasts. I thought I knew something about myofibroblasts. But good Lord, all the number of different tumors and tumor-like conditions he talked about, I haven't even heard of them, some of them. And one of the reasons I haven't heard of them is I stopped reading about surgical pathology about 10 years ago. Because, well, I never read textbooks anyway, even when I was a resident. I learned by looking at cases. I never learned by reading about cases. Now, I must say, when I was a resident, when I saw a case, I'll go back to the book and read about it. But afterwards, I didn't do that because I saw so many cases that it was really not necessary for me to read about it because I got my own experience. And now, of course, I don't have that kind of experience that I used to get. So I have a lot of experience to talk about when I talk about learning. Now, how many of you went to medical school? All of you, right? How many of you went to college? All of you. How many of you read classical literature? Oh, a few, that's good. This disease is beyond my practice. Who says that? And in what? Yes. Well, you said something, you raised your hand. This disease is beyond my practice. Anybody know where that is from? And that applies to all of us. When we want a second opinion, is that what we are saying to ourselves? I don't know what this tumor is. So let us send it to Dr. Schuster. And he probably knows what it is and he will help me. And it is one of the great things that we do in surgical pathology. One of the great fun things of surgical pathology is to share cases. You get an unusual case of a myofibroblastic tumor, for instance. And if you have Cooper, down the hallway from your office. You walk down there, put it on his microscope and say, "Cook, tell me what this is." And that is what surgical pathology is all about. This actually is from Macbeth, written by Shakespeare, of course. And this comes from a doctor who is called in to treat Mrs. Macbeth, or Lady Macbeth. And you remember the scene where she's walking around in her sleep and trying to wash her hands of blood. And the doctor who is watching her says, "This disease is beyond my practice." What a wonderful way to say that this is not in my realm of practice. Somebody else has to look at it. Unfortunately, there was no psychiatry at that time, though Shakespeare probably knew more about psychology than Freud, I suspect, but no psychiatrist. And this is what we are really going to talk about. You know, what happens when you come across something that we really don't know and we need help? So I thought to myself, who did the first consultation in surgical pathology? Who was the first pathologist who said, "I don't know what it is, but so-and-so may know what it is"? And who was that so-and-so? Was it Virchow? Virchow was a very interesting man. He is generally considered to be the father of pathology. Who the mother of pathology, I have no idea. This is what Virchow looked like when he was a young man. And apparently he was quite a firebrand, a revolutionary. But he's one of these guys who looks better when he gets older. He's much better looking as an old, wise man. And he indeed was. I mean, he gave us a lot of our understanding of pathology in general. And I'm particularly fond of him because he apparently was the first person to use the word osteoid. A very important word. Was it Arthur Purdy Stout who first recognized, as a consultation, who was first recognized for his expertise in surgical pathology? He truly was a great expert in surgical pathology. He started out as a surgeon, as a lot of surgical pathologists did in the old days. And he probably is the person who really started surgical pathology in the United States. James Ewing, great pathologist at Memorial Hospital. He was the chief of surgical pathology at Memorial. And of course, there is a tumor named after him, Ewing tumor, in our own practice at the Mayo Clinic. And let me say that much of what I have to say today comes from my experience in the Mayo Clinic. I worked as a consultant at the Mayo Clinic for about 32 years. And almost all the material that I'll be showing comes from the Mayo Clinic. Now, when I left the Mayo Clinic, I left all my material, all my slides, everything I left there. I didn't bring anything. But there were some digitized photographs, and that's what I'm using for giving this talk. This is Malcolm Doherty. He was a legend in surgical pathology at the Mayo Clinic. The surgeons just loved him because he obviously enjoyed doing surgical pathology. And that's one of the lessons of surgical pathology. It's fun to do surgical pathology. It's not a chore. And if you're called in the middle of the night to do a frozen section when you're fast asleep, don't think this is disturbing my sleep. Think that they want me. If you are not called in the middle of the night, that's when you start worrying. Because that means they don't need you to do any work, and you will be out on the street like another several million people in this country looking for a job. So be grateful that the surgeons need you. But this is the most important thing about Malcolm Doherty. He had this infectious enthusiasm for his work. And I think that that's one of the things I learned from him. I just love doing surgical pathology. Now, there are several other people who at least influenced my career at the Mayo Clinic, and they're all characters in the true sense of the term, because they all have great personalities. Like Dr. Woodward, for instance. If I had said this quotation from Macbeth, Lou Woodward, who is 98 years old, probably would tell you where it is from, because he remembers all of Shakespeare, which he learned when he was a young man. Dr. David Ali is my mentor, greatest bone tumor pathologist ever, certainly one of the great surgical pathologists of our time. Ed Soar was interested in soft tissue tumors, but like everybody else, he was a general surgical pathologist. And Lou Weiland, several of you know Lou Weiland. He was one of the persons who was instrumental in building up the practice of consultation pathology at the Mayo Clinic, and George Farrow. And these are the people who were there when I went as a resident in 1967. And this was an all-star cast. So no wonder I got very interested in this field of surgical pathology. But all of those people, Dr. Darlene was the one who attracted me most, and that's why I went into the field of bone tumors. And how were they able to build up this practice? And I will show you the numbers as to how many cases in consultation they saw. And the simple answer is good service. If you get a case in consultation, and not necessarily in consultation, if you get a case sent in by one of your surgeons, it's a breast biopsy process, don't sit on it. Do it right away, as soon as possible, at least within 24 hours. Because remember, this breast biopsy is extremely important to one person, the patient. And if you sit on it and diddle with it and do all kinds of special stains, which are probably unnecessary, then you are just making this patient more and more anxious, because she wants an answer. She wants to know, is it cancer? So these are the number of consultation cases that actually I saw personally. Now, I didn't notice till yesterday that the secretary who used to work for me at the Mayo Clinic made this up. She has given every other year. So all of these total together, about 75 to 100,000 cases. So I personally saw about 75 to 100,000 cases in consultation alone. And I, of course, did everything else at the same time. I did frozen sections. Frozen section was my favorite profession. I did what we call clinic centers. That means patients come to the Mayo Clinic, a biopsy is done, let's say, in Brookfield, and the slide is sent in for our confirmation. I used to look at those too. I used to do cytology. I never did the gynecologic cytology, but I did non-gynecologic cytology. So I think I pretty much was a good general surgical pathologist. Now you notice that there are some years when it started going down, and I looked at it and I said, what was going on? Why was I not getting as many cases as I used to? And I comfort myself by thinking that when you get older at the Mayo Clinic, you get more and more time off. So after 60, you get 6 weeks off. So I was probably gone for about 9-10 weeks a year. And somebody else was taking these cases. At least that's what I know. So what lessons did I learn from seeing all these cases? Because that is really the way to learn thinking. The more you see, the better you get. If you see 10 solitary fibrous tumors, it's very likely that you will recognize the 11th one. But if you have seen only one solitary fibrous tumor, it may not come back to you. Because after all, surgical pathology is just visual memory. And we just hope that when we look through the microscope and see a slide, those signals will hit that neuron which is encoded this diagnosis of solitary fibrous tumor or a chondroblastoma, whatever the case may be. And I'll give you one example of why seeing a lot of cases helps one understand a disease process. This is an article written by Renee Philippi. She was a visiting clinician from Brazil. And when she found these 26 cases of this peculiar type of osteoblastoma, we had about 800 odd cases of osteoblastoma in the Mayo Clinic files. Most of the consultation cases that Dr. Darlene and I had seen, I figured that for every case seen at the Mayo Clinic, say of an osteoblastoma, I would have seen about 8 cases in consultation. And it stands to reason that unusual cases are more likely to be sent for consultation. So there will be an overabundance of atypical cases in the series of consultation cases. And so this is the history of one. This is unusual because osteoblastoma involves the body. It involves the posterior elements, not the body of the vertebra. But in this particular case, it involved the body of the vertebra. And this is pretty typical of an osteoblastoma. A very loose arrangement of the tissue. The cells are not back together side to side or back to back. But notice that there are some atypical cells. And if you are unlucky enough to get one of these in a fine needle aspiration, good luck in making the diagnosis of a benign lesion. But notice also that these nuclei really do not look hyperchromatic. Enlarged, yes, kind of dark looking. But if you look at it closely, they have this kind of bubbly nuclear feature. The chromatin is not closely packed together. And that is how I make a diagnosis of a benign lesion. Just to say a few words about osteoblastoma. There was one pathologist from New Zealand who came and spent some time with me. And she, I kind of thought, undiplomatically asked me, what is the most difficult case that you have, most difficult diagnosis? I thought she would say, everything is easy for me, but that's not what she got. But osteoblastoma is really the answer. That is the one which gave me the most trouble. I have overdiagnosed osteoblastoma as osteosarcoma and underdiagnosed more often osteosarcoma as osteoblastoma. It's much more easy to underdiagnose an osteosarcoma as osteoblastoma, unfortunately. But this is pretty typical of an osteoblastoma. This looks just like an osteoblastoma with a lot of thick sclerotic bone. Osteoblastoma is, after all, just a big osteoblastoma. But the clinical features may not be as typical as is usually seen in osteomas, such as pain related with aspirin, worse at night, and so on. May or may not have posterior elements of the vertebra, whereas giant cell tumors involve the body of the vertebra. And here is another example of that. Sometimes you see these lesions which are primary within the medullary cavity. In the cortex, actually osteoblastoma and osteoidostiomas are two tumors which have a tendency to involve the cortex. Adenoadenoma will be another one. They can occur on the surface of the bone. And occasionally you will see one in the soft tissues. I've seen what I think is an osteoblastoma clearly in the soft tissue. This is the problem with osteoblastoma. There is no radiologist who will say this is benign. It looks like a permeative, destructive lesion involving the bone and extending into the soft tissue. It should be malignant by all counts, but it's not osteoblastoma. And you have to see a lot of them to have the confidence to say, I don't really care if the radiologist says it's malignant, it's still benign. And this is a gross appearance. This is a case which was sent to me by Jeff Myers, and it clearly shows a cortical involvement, but it also involves the medullary cavity and expands into the soft tissue. But this is usually how it comes out because it involves the vertebra. And spine surgeons don't do such a great job of removing them as orthopedic surgeons. This is a beautiful example of the lower part of osteoblastoma. It just looks like an osteoblastoma. There is some sclerotic bone around it at the periphery. And it's just a size which makes me say it's an osteoblastoma rather than osteoblastoma. The periphery of the lesion, extremely well demarcated, not permeative, a few big cells, that's not uncommon in osteoblastoma. They are scattered about and not closely packed together. Now the name osteoblastoma comes from this, that there are a lot of osteoblasts rimming these bony connections. And I think that's a good term. Sometimes you will see this lace-like osteoid and a lot of capillary proliferation. That's why an osteoblastoma will be red and granular. It's very important to look at gross specimens in surgical pathology. And people who sit in their offices and look at the slides are really short-changing themselves. Go look at the gross specimen. It tells you the diagnosis almost all the time. And this capillary proliferation will not be seen in an osteosarcoma. Sometimes you will see clusters of tumor cells as you see there, and lace-like osteoid, some spindle cells. It used to be said that you never see cartilage in osteoblastoma, but you do. If you look at a lot of them, you recognize that the presence of cartilage does not make it an osteosarcoma. This is the problem. If you see this pattern of bone, osteosarcoma is a diagnosis. But this was in the middle of an osteoblastoma. So you can't see that in an osteoblastoma. The edge is well demarcated. And this is what oral pathologists call a cementoblastoma, around the root of the tooth. And this has this very characteristic parallel, almost a sunburst appearance of bony defect, as you see here. This is a surface osteoblastoma, and this is a very famous case. I don't know if I have the time to tell you how it is famous, but this was seen by Jaffe, Lichtenstein, probably Ackerman, and Dali. And they all called it osteosarcoma and did an application. And Dr. Dali recognized for what it was after the application was done. And this is a gross specimen, which is a pretty old one, as you can see. And this is what they saw, multiple little niduses, or nidi, I don't know what the right term, osteoblastoma with sclerotic bone. This is another problem with osteoblastoma. They have epithelioid-looking cells with nucleoli, which almost look like they are looking back at you. And when you see that again, if you see that on fine needle, good heavens, it will be very difficult to make a diagnosis of benign lesion. But if you recognize that these kind of epithelioid cells are not uncommon in osteoblastoma, as in this case, young kid from Germany. He had had a biopsy done in Germany, was seen by a good pathologist, and he came to the Mayo Clinic after being put on chemotherapy for an osteosarcoma. This X-ray was seen by a colleague, Dr. Bieva, a radiologist, and he said, this is an osteoblastoma. Look at that nidus. And there is this loosened area around that. He said that is very typical of osteoblastoma. So I had a leg up. I could look at this case and say, this is an osteoblastoma, because that's what Dr. Bieva said it was. And the CT scan clearly shows this nidus surrounded by the loosened. And this is a gross specimen, microscopic appearance, somewhat epithelioid looking, and patient was very happy. Went home to Germany. And this is another problem with osteoblastoma, that it can look extremely worrisome on histology. One of the rules I used to use was that there is always bone formation everywhere in an osteoblastoma. You should see cells without bone formation. But here is one, which I thought was an osteoblastoma, but it had these areas of pure cellular growth. Now, how do you say it's not an osteosarcoma? Because you looked at the rest of it. And here's another example of an unusual type of osteoblastoma with pleomorphic nuclei. And this patient with an osteoblastoma presented with paraneoplastic syndromes, fever, macroglobulinemia, and so on. So all kinds of things can happen with. I will finish up with this case. This patient was an orthopedic surgeon, came to the Mayo Clinic from Florida with the diagnosis of osteosarcoma, with that X-ray. And that's a CT scan. And he was convinced, and he was told it's an osteosarcoma, and he came to the Mayo Clinic to be treated by Dr. Frank Sim, who was a great orthopedic oncologist. And he did a lot of hemicalvectomies. And he did a biopsy. And my colleague, Dr. Ward, who's one of my younger colleagues, was in the process actually at night. You know, these orthopedic oncologists have a tendency to do these tough biopsies at 9 o'clock at night. And I was safely at home by that time, so he couldn't show it to me. And he said it's an osteoblastoma. And sure enough, that is how what it was. So the end result was this patient came to see me and thanked me for saving his life. And I told him very honestly that I had nothing to do with it. It was somebody else who made the diagnosis of osteoblastoma. But he thought I was just being humble, and he insisted on thanking me. And it's so rare for pathologists to get any thanks that I said, okay, fine. Dr. used to say that pathologists get only tuberculosis for patients. So this is one thing we have to remember when you see a biopsy. It is a business of some heat. Where is that from? Anybody know? That's from Othello. Othello is being told that he has to go to Cyprus to fight the Turks who are invading Cyprus. So one of the people coming to tell him, this is an important thing. You have to take care of this quickly. And that's what we have to do too. We have to be prompt because there is a patient. Who knows what this patient has? That's a syndrome. What's wrong with her? I'll show you another. What's wrong with her? Hand. No thumbs, right? She has Rothman-Thompson syndrome. And those patients are likely to get osteosarcoma. So we don't want this to be told. I certainly don't want anybody to tell me that you know everything, because I don't know everything. But a day to day. I want to be able to tell them today what the diagnosis is. And it's very important to communicate with the clinician, with the radiologist, whosoever it is. And I do it with the phone, not with the internet. I think the computer has been one of the worst things that has happened to surgical pathology, to medicine, because people don't communicate with one another. Nobody picks up the phone and calls somebody else. Send an email. People sitting next to me, the next office will send me an email. Why not come around and tell me? Because I don't read emails. This is another thing. I don't use abbreviations because that is asking for trouble. Don't talk in abbreviations. Why not say aneurysmal bone system? Is that difficult that you have to say A, B, C? It's not that tough. Now this is a kind of a mouthful. Pseudoangiometastropal hyperplasia. I had a case like that when I was at the Mayo Clinic, and I called up the clinician to say, this patient has pseudoangiometastropal hyperplasia. And this is the clinician. She had no idea what I was talking about. And then she said, oh, patch. So that taught me a lesson. Important to keep track of cases. Like this, like this, like this. And of course, it's a cornfield. That's what all we had around Rochester. So there was nothing to do but work. And I tried to continue to keep track of this case. Because that's how we learn. Making mistakes is unavoidable, unavoidable. But when we make a mistake, we have to admit we have made a mistake. Now, who knows where this is from? And thus, the native hue of resolution is sicklied over with a pale cast of thought. That's Hamlet. Of course, he's talking about committing suicide, why he's not able to bring himself to actually commit suicide. So I would recommend this, but I think it is important that don't spend too much time thinking about the diagnosis. Most of the time we make diagnosis intuitively, not thinking about it. I have never been able to make a diagnosis by thinking about the case. Either I know it or I don't know it. Now that doesn't mean that it's an awesome case. So we need organization for consultation cases, and Lou Weiland is one of my heroes. He was one of the persons involved with the development of consultation cases. I asked my secretary, who was my secretary at the Mayo Clinic, that was the last year I spent there. There were 47,000 cases. And now there are only 45,000 cases. I wonder if it has anything to do with my leaving. And I told you Nascimento, he is a great friend of mine, Brazilian pathologist, and one of the great true general surgical pathologists of our time. And he was happy as hell doing consultation cases. He used to do about 6,000 cases, but that's all he did when he was finally at the Mayo Clinic. Thank you very much. I suspect you don't have any questions about this. But if you have, of course I'll be happy to answer.